So my name is Roxanne Cogil, and I'm the Director of Iowa for the Epilepsy Foundation. We provide support and services to individuals and families living with seizure disorders and epilepsy. One of the biggest things we do is we provide education to a variety of groups across the state, and we do travel all 99 counties across the state of Iowa. And we have trainings for school staff, school nurses, high school students, middle school students, elementary students, as well as daycare centers, senior caregivers, agency, SEL, respite provider staff, law enforcement, first responders. So just a variety of groups. And we educate, and we don't charge for our trainings because we are funded to educate. We also have support groups around the state, and we take calls from people that are having some challenges. There's a lot of challenges with people with employment, housing, transportation, schools, seizure action plans. And we try to help guide people to resources to overcome some of those challenges to help improve their quality of life. So today is our basic training on seizure recognition and first aid. And the objectives of this training is to be able to recognize common seizure types and how to respond to them, seizure triggers, as well as situations that are definite medical emergencies, and what you can do to support those that you work with that have seizures. I got involved with the Epilepsy Foundation because our daughter started having seizures about 12 years ago. And she was 2 years old, and she just started having seizures out of the blue. And to make a long story short, her seizures, she had multiple types of seizures, and the medications didn't work so well. She had intractable epilepsy, and she ended up having to go through a couple brain surgeries. She's doing really well now, but it was really rough in those early years. And it was so rough to the point where once we got her to a better place with her seizure management, I just started volunteering. There was just such a great need to help people get to a better place, and especially when so many people are so fearful of seizures. And so that led to full-time work, and we continue to add programs and services in our state to help with that. But a seizure is a brief electrical discharge in the brain. It can alter movement, behavior, sensation, or awareness. And many people don't realize it, but 1 out of every 10 people will have a seizure in their lifetime. 1 out of 10. It is so much more common than what people think about, but people are so fearful to talk about it. And I think a lot of it has to do because of the lack of education and the stigma surrounding it. But epilepsy, not all seizures are epilepsy. What the doctors are looking for epilepsy is they're looking for that repetitive pattern. They're looking for those symptoms that occur over and over and over. Epilepsy is a chronic neurological condition. And when somebody suspects episodes, symptoms, spells, or events, we strongly recommend that they get in to see a neurologist and basic diagnostic workup. It often includes a 2 to 4 hour video EEG. They'll do an MRI. They'll draw blood work. And they'll gather information from those parents, guardians, and loved ones, spouses of who've witnessed symptoms. And they'll take all that information and data to try to come up with an epilepsy diagnosis or a diagnosis that perhaps it could be some other type of medical condition. We do see the words epilepsy interchanged a lot with the word seizure disorder. So epilepsy is one type of seizure disorder. But epilepsy is so much more common than what people realize. It's one of these hidden disabilities. And because people are fearful to talk about it, they don't realize how common it really is. People don't realize that 1 out of 100 people live with epilepsy today, and 1 out of every 26 people will develop epilepsy in their lifetime. 1 out of 26, that statistic is just astounding. Now, epilepsy is a diagnosis that can happen literally to any one of us, anywhere, at any time. But we do see in the toddler years between the ages of 2 to 4, which was the time frame our daughter got diagnosed. We see an increase in the teenage years at the onset of puberty. And we see the diagnosis skyrocket in the elderly. The elderly are more prone to brain tumors, strokes, and falls, and all those things could potentially lead to an epilepsy diagnosis. But unfortunately, if people haven't been educated, people tend to only know the myths surrounding epilepsy. I always say you don't know what you don't know. I mean, people know what they think they know. Most people don't realize that most seizures are not medical emergencies. Generally speaking, you don't need to call 911 every single time somebody has a seizure. But if you have a child or a loved one, or you're working with somebody in the school setting or with that agency, it's important for you to know how frequent are their seizures? What do they typically look like? Do they have a warning? Are there known triggers? What's their recovery time like? Because for somebody where they have an epilepsy diagnosis and they know what's a common seizure type for them, then that's just a common pattern. But if they're exhibiting symptoms that are not typical, then that could be a potential cause for concern. Many people, when they're in a seizure, they don't remember what happened. And that may need to be explained to them afterwards. Just because we see somebody in a convulsive seizure doesn't mean that they realize it happened. I've witnessed hundreds of convulsive seizures, not only in my daughter, but also in other people. And many times, people deny that they were even in one because they don't remember that they were in one. And so sometimes that may need to explain to them. All they know is when they come out of it, they're very groggy, they're very tired, and why is everybody staring at me? And that needs to be explained to them. Now, children, if they haven't been educated, they think that epilepsy is contagious and they can catch it. And it's important to educate children so they know that it is not contagious. They can't catch it from somebody. Because what we see happen in the school setting is sometimes those students will socially isolate themselves from other students, and we don't want that to happen. Or they start imitating the seizures of what they witness. Epilepsy is not a mental illness. It's not a mental illness. Epilepsy is a medical condition. Asthma, allergies, diabetes are medical conditions, and so is epilepsy. People need to see their doctor. They need to take their medication on time every time to help manage their seizures. Some people with epilepsy have coexisting conditions with mental illness, and actually the number one coexisting condition with epilepsy is depression. About 30-35% of people with epilepsy are also on the autism spectrum. People with cerebral palsy have a higher risk of getting epilepsy. And if somebody has cerebral palsy and an intellectual disability, the research shows over 50% of that population will also have epilepsy. And even children who have an ADHD diagnosis, about 40% of them will have epilepsy. So if there's anything abnormal neurologically in the brain, people are just at potential greater risk for developing epilepsy. It is rare for somebody to die during a seizure, but it can happen. But some people think it's frequent, but it's not. It is rare. And the most common form of death with epilepsy is SUDEP, and it stands for sudden, unexpected death in epilepsy. Now, our doctors told us 10 years ago that our daughter was at high risk for SUDEP, and we had never heard of that term back then. And the doctors are educating families and individuals with epilepsy a lot more about this potential risk now. She was at high risk for SUDEP because she had multiple types of seizures. She had seizures not only when she was awake, but also when she's sleeping. And she would also frequently, her lips would turn a very darkish, bluish, purplish color during her seizures. So her seizures affected the autonomic portion of her brain, and that's a part of your brain that controls the heart rate, the blood pressure, the breathing, the body temperature. And her seizures were refractory to treatment. They weren't controlled with medication. And there's a lot more research going on for SUDEP, and the really exciting thing is even in our rural state of Iowa, the University of Iowa are one of the leaders across the country in SUDEP research, and they're figuring out why that respiratory function shuts down in some people after a seizure during their sleep. So they're starting to figure out some of those pieces. But right now, the only way to prevent SUDEP is to control the seizures. And that's why as an epilepsy foundation, we advocate pretty hard on access to all potential treatment options for seizure management, because whatever that physician wants to recommend for that patient, we want them to have access because it could help them manage their seizures. The other thing with death is sometimes it's those circumstances. Seizures can occur anywhere at any time. Some people, they drown in the bathtub, or they happen to be walking or up or down steps. And because some seizures are so unpredictable, that can be very difficult to manage as well. But overall, it is very rare, and the majority of seizures will run through its course and it'll end on its own. Some of you may remember back in the day, they used to teach to put an object in somebody's mouth during a seizure. And that's because they used to think that people would swallow their tongues. But the medical professionals say the tongue is a very strong organ in the mouth and it's physically impossible to swallow. We don't want to put an object in somebody's mouth because they could chip a tooth, they could break their jaw, they could break off the broken piece, they could choke on it, and a lot of harm could come to that individual. You never ever want to leave anybody on their back during a convulsive seizure because we are worried about that tongue blocking the airway, that they could swallow, that saliva could go back down in their throat and they would be at risk for aspirating on that fluid. Which is why if somebody's in a convulsive seizure, we want to roll them on their side, let that tongue hang out of the mouth so that saliva can drain out of the mouth. Never ever put an object in somebody's mouth during a seizure. That is the big teaching that has changed over the years. So when you think about the causes of epilepsy, this is very hard because 70% of the time the cause is unknown. What if it were you or your loved one? You get diagnosed with this chronic neurological condition and you walk out of that clinic with no answers. And if you're a professional working with families, you will have emotional parents because when you get this diagnosis and there's no answers and the doctors don't know why, it is very difficult to come to terms with and to just go through that cycle. But for 30% of the people with epilepsy, they can identify a cause, and many times it's not good. Something shows up on that MRI scan. It could be brain lesions, or they could see scar tissue from after they removed a brain tumor, or they could see evidence on that MRI from stroke or some type of brain injury, which actually brain trauma and brain injury is the most identified cause of epilepsy out of those causes that can be identified in teenagers and young adults. Stroke is the major identified cause of epilepsy in the elderly. Lead poisoning, infections of the brain. Some individuals are born with a brain injury. Perhaps they were born with suction cup or forceps, or they had apnea blue spells, or they had a congenital malformation and they started having seizures right away at birth. Other individuals were born on time, developmentally, they meet all their milestones and get hit with an epilepsy diagnosis down the road. So it certainly is a spectrum and it can vary. I know numerous people with epilepsy. They lead a completely functional, completely normal life. They just need to take their meds on time every time, and it manages the seizures. And I know plenty of other people where epilepsy is one of a multitude of medical diagnoses, and it's a much harder road, especially if the medications don't work. There are over 40 different syndromes of epilepsy and over 20 different kinds of seizures. Before our daughter was diagnosed, the only thing my husband and I had heard of was the grand mals. But those aren't as common. Over half of all types of seizures are partial seizures, and the symptoms can be very subtle and difficult to recognize. So I'm just going to go over the 4 most common types. So you have the generalized seizures, which means those are seizures that come from both sides of the brain. And so what this would look like to you, it would be somebody staring, the limbs jerking and shaking, the stiffening, and the drops to the ground. The partial seizures, otherwise known as focal seizures, only a portion of the brain is involved. The rest of the brain is completely unaffected during that seizure. And the clinical symptom that is observed during that event, it relates to the part of the brain that controls that function. So for example, if it's just my left arm jerking, it's the right motor strip controlling that function because the right side of the brain controls the left side of the body and the motor strip controls the motor movements. The rest of the brain is normal brainwave activity during that seizure. How many of you have heard of petit mal seizures? Yeah, so that's what absence seizures are. They're those quick staring spells. That's what they're commonly known as. Are they or aren't they? Because it's staring, and staring can be a lot of different things, especially if you're working with a child with special healthcare needs and focus and attention challenges. But for absent seizures, it's the child will have, or the person will have a pause in activity, and they'll be staring off. You could be saying, Johnny, Johnny, and Johnny's not responding to your questions. It's a brief lapse of awareness. On average, the staring will occur for 1 to 10 seconds. Sometimes, but not always, there's rapid chewing motion with the mouth or blinking motion with the eyes. And the only true way to know if it's just somebody not paying attention or if it's an absent seizure is for the doctors to look at the data. And so when they do the video EEG, they put the electrodes on the head to monitor the brainwave activity. Is if they can capture if these staring episodes were to occur while they're hooked up with the electrodes, then the doctors can tell by looking at the brainwaves on that monitor if it's an absent seizures and they need to be on seizure medication, or if it's a normal brainwave activity, it's probably, maybe just focus and attention challenges. Maybe it's just ADHD or something like that. But this event is often confused with a person daydreaming, not paying attention. And some kids get a diagnosis of attention deficit disorder, and really it's an undiagnosed epilepsy disorder with absent seizures. So the absent seizures, both sides of the brain is completely involved. And that's why it's important to get a good diagnosis, and if it is seizures, then they need to be on medication to help manage that. Because a lot of people that have this, they have hundreds of these a day. And when they're in that brief staring episode, they don't remember a thing. And that's one of the things that the doctors say that you can do. So if somebody's staring, if you were to snap your fingers or to touch their shoulder, they're not going to respond to that touch or stimuli. But if somebody's just not paying attention, they're going to respond to that. And they're going to remember what's said. But if somebody's truly in an absent seizure, they're not going to remember anything that's said or anything that occurred during that brief event. So that's something else you can do. You can ask them, well, what did so-and-so just say? Or did you remember what I just asked you? And usually they don't remember anything until before. They mention the last thing they remember is what was said or what occurred before they went into that staring. So they're brief staring episodes. So you can think about it like a light switch going on and off. They're in and out, in and out. Throughout the entire day, they're missing snippets of instruction and they have no idea they're missing gaps of time. And for the majority of the people, being on the right seizure medication can help manage this. So this event often gets overlooked, and many times, if the teachers have been educated, it's somebody that, like a teacher in a structured environment, that picks up on this and alerts the nurse who calls the family. He goes in to be seen and gets a diagnosis, and they get on meds, and then it's managed. But if the absent seizures go uncontrolled with medication or they go undiagnosed for a period of time, in some people it could lead to the generalized tonic-clonic, because the absent seizures, even though they're brief staring episodes, both sides of the brain is involved. So generalized means both sides of the brain is involved. Tonic means stiffening of the limbs, and clonic means rhythmic jerking. So you got the stiffening of the limbs followed by the rhythmic jerking. Many times, because at the onset of this event, because the diaphragm contracts, the person will have a loud, pierced scream or a loud, hoarse cry. And many parents describe they only know their child goes into this event if they're in the other room, as if they hear them, with a quick scream, and they go in and they see them in a full-blown seizure. They have an immediate loss of consciousness. Usually they'll fall to the ground. If they're sitting at this table here, it could look like a full forward body drop, and sometimes their head will go down and it'll hit that table, or they'll fall out of the chair. There were many times with our daughter, we would be walking and talking, and I was never quick enough to grab her because there was no warning. I couldn't react that fast. She would just go down, go down, go down. She'd hit her head, and it wasn't long we had to get one of those seizure helmets for her to wear to protect her head. In other people, they do have that aura, or they have that warning. They have some type of odd sensation before that seizure. And there were a couple times she had that. And it's different for everybody, but for her, she'd be walking, and then all of a sudden her movements would go like this, just for a couple seconds. But it was enough for me to get to her to break her fall, so she wouldn't go down quite as hard. There's a lot of convulsions with a seizure, and I can talk about it all I want, but if you've ever witnessed one, it never leaves you. I mean, it is such an intense event. It is so hard to see somebody just so helpless in this event. So it's bilateral with upper and lower extremity is shaking. And there's a lot of shallow breathing, a lot of gargling noises with the mouth, a lot of saliva coming out of the mouth. Some people foam at the mouth. The breathing is very labored. I know there were times we thought we'd lost our daughter because she would just go limp. But when I leaned down to listen, I could hear her breathing, but it was just so faint. It would get so faint, and it was so scary during these events. With some people with this event, they have possible loss of bowel or bladder control. Other people had the cyanosis where they had the immediate color change and the nail beds, skin, and lips will turn blue. Not everybody, but some people. If you've ever witnessed a tonic-clonic seizure, it seems like it lasts forever, and that time just stands still. It seems like it goes on and on and on. And that's why it's really, really important to time the seizure, because if people don't time it, it seems like it lasted 10 to 15 minutes, when maybe it really only lasted a couple minutes. But on average, 1 to 3 minutes is what it lasts. When the shaking is stopped, it's what we call the post-ictal stage. It's the recovery stage. The seizure is over. They're coming out of it. They're opening their eyes. They're very groggy. They're very tired. If they're trying to talk, sometimes their speech is still very slow and it's slurred. Our daughter could not get up and walk. Her whole left side was just limp. She could not walk. If we were in a grocery store or department store, I'd have to get a wheelchair, get a stroller, or I'd have to carry her back out to the car because she could not walk at all after these events. The recovery time is different for everybody, and it's important to know the recovery time because you could be anywhere and you need to know where you're going to take it, because for most people after this event, they immediately want to go to sleep. They need to sleep it off. It just takes everything out of them. Now, for our daughter, it would take a good 2 to 3 hours after every one of these seizures to fully recover. There were days we had to prematurely woke her up because we needed to go somewhere. I couldn't hardly wake her up out of that deep sleep. But if we let her wake up on her own, it's almost like the brain knows how much time it needs in order for it to reset itself. And when she'd wake up on her own, she was good to go again, like nothing happened. But some days she would start clustering. The next seizure would occur. And so we would have to hurry up and feed her and take her to the restroom before that next one occur. And some days she would cluster where she'd have the next seizure before she even woke up from the previous one. And then we would have to administer some rescue medication to break up that cycle. So here's a few video clips of what the tonic-clonic seizure looks like. So what do you do if you see somebody in a tonic-clonic seizure? It's very important to stay calm. You don't want to be yelling seizure, seizure, and creating unnecessary chaos in an environment. If somebody's in a school, the teacher will have the other kids exit the room for privacy, have somebody get another teacher to come in to assist. If it's somebody you don't know in the community, you want to check for a medical ID. And by the way, the Epilepsy Foundation, we give out free medical ID bracelets and necklaces, fabric wristbands for kids, and shoe tags to anybody that would like one. It was the call I got from somebody who was wrongfully arrested during a seizure and he was in jail. And I thought, gosh, if he just had a medical ID, could have that prevented that wrongful arrest? So I wrote for a grant a few years ago, got medical IDs, and we've been giving them out ever since to help keep people safe. I do have a few with me today, I think. You want to protect them from hazards. So as the limbs are jerking and shaking, you want to move the tables and chairs. You want to move things out of the way. You want to roll them on their side. Either side will work, but the medical professionals prefer the left side because the way the heart is positioned, it allows for easier breathing. You want to cushion the head. You may or may not have a pillow nearby. I'd grab a bag, I'd grab a coat. There were times we would be on the concrete cement, like on a playground, and I had nothing with me in the middle of summer. So I would have to cup my hands to cushion the blow of that head from hitting that hard surface. If they have glasses, you want to remove the glasses. You want to loosen up the zipper on that coat, the buttons on that shirt, that tie. You want to keep that airway as open as possible. Now, if they're sitting in that table right there, or that chair, if it's a smaller child and it's safe to ease them to the ground, to their side, then do so. But for anybody that's our size, adult size, it's not going to be safe to do that. You're going to want to support the head. If the head goes back or forward, it's going to cut off the airway. So you want to support that head to keep the airway as open as possible and make sure that saliva is draining out of the side of the mouth and not going back in the throat. That's very important to remember. You probably want to grab something to cushion underneath the arms from hitting that table and to support the head. If their legs are wrapped around that chair, you don't want to pry them out of that chair or pry them out because they could fracture a limb. Their limbs are going to be stiff and it's going to be shaking. And you don't want to force those limbs to do anything it's not supposed to do. Again, the majority of the seizures will run through its course and end on its own. You never, ever want to leave anybody unattended during a seizure. Somebody needs to be there with them and to keep them safe. And again, you want to be there to provide emotional support after the seizure is over and to document the seizure activity. It's very important to know how long did that seizure last, and when you time the seizure, you don't time the recovery stage. You only time the length of the seizure. And you write down what you observed. Did the eyes roll? Which limb shaked? Was it one arm? Was it the right arm, the left arm, or was it both arms? You know, did they drop to the ground? Did they fall to the right side? Did they fall to the left? You know, and we have seizure observation records that list a lot of the symptoms, and a lot of the schools like it, or the agencies, because they just check a box of what they see. And it's not a lot of paperwork, but at least you have some type of documentation. Because this is very important for the families to get to their neurologist so they can adjust their medications to try to help manage the seizures. So here's a couple of video clips of that post-ictal stage, that recovery stage. So after the seizure is over, what that looks like.
Calculating the 5 minutes. Keep in mind there is always a period following convulsion where the person is unconscious or extremely groggy. This is known as the post-ictal stage, and this time period is not included in the 5-minute calculation. Going on, and you need to call medical services. You need to be there reorienting the individual.
Any questions on how to recognize or respond to the two most common kinds of seizures, the absent seizures or the generalized tonic-clonic? So the question is waking up, the recovery stage after a seizure. So a lot of times after a convulsive seizure, people need to sleep. The length of time that they need to sleep after a seizure, it varies from person to person, and it varies from after a seizure to seizure. But if after a tonic-clonic seizure for our daughter, it was hard to wake her up if she was still in that deep sleep. Now in the mornings, it was interesting because we didn't know she was having seizures at night for, about a year. We thought she was getting a break at night. But what we started noticing, or we started figuring out, is she would sleep for 12 hours at the night, or so we thought. She would come into the kitchen to get breakfast, but she was yawning and tired, and then I turned around and I couldn't find her, and I went back in her room and she was in a deep sleep. So I started leaving her door open, and one night I was walking by her room and she was in a tonic-clonic seizure on her back in blue, and I didn't know, and that's when we got a audio video monitor to monitor that at night. But it can vary. And some people don't need to sleep after a seizure. It just varies. So that's why my point is, for those loved ones, just know what the recovery time is like and what's typical for them, for their seizure type. Yeah, good question. Any other questions on that? So how many of you knew that somebody could have a seizure and still be fully conscious? Yeah, I can just tell by watching. You guys all know somebody, have loved ones, work with somebody, because you guys I can feel it. Well, we did not know, or do you have a question? Yeah. Yeah, so usually you want to leave them. So in that situation, if they're shaking, you'd want to roll them on their side so that saliva can drain out of the mouth. You want to keep them safe until that seizure runs through its course. Yeah, there was really not a whole lot you can do. When you think about it, it's very basic. But these little things can really make a big difference. Well, the turning on the side is if they're shaking, if they're in a convulsive seizure. Yeah, if they're not in a convulsive seizure, no. Now, if you come upon somebody in the community, the first thing I do is look to see if there's a familiar person around. If there's a familiar person, they're going to know. They'll say, I got this, we're familiar, they have this, you know. But if there's nobody with them, that's harder. That's why you want to look for a medical ID, because it could be a seizure, it could be something else that looks like a seizure, but it's not. It could be a heart attack, could be something, stroke. Yeah, and that's why, because a lot of times when people don't know what to do, they call for help. And that's why we have a specific training, a CDC training for law enforcement and another one for first responders, so we can educate them on knowing what to do. So we do have a training, we do have a specific training for employers. So if we know with somebody that has epilepsy that got a job at a place, we can go in. If they have disclosed their epilepsy and they would like that training, we have gone in to employers to train management and coworkers. We can do that. So simple partial seizure we did not know this until before our daughter's first brain surgery. We were on the epilepsy monitoring unit. And, you know, they have that little marker, so when they have a seizure or episode, you press that button, it marks the tapes, so the neurologist knows where to go back and look at it. Well, the techs are in the rooms looking at these monitors all the time. Well, the tech come up to the room and he said, Roxanne, you didn't click that marker, she just had a seizure. I said, she just didn't have a seizure, I've been with her. He goes, no, she just had one. And I said, no, she didn't. I go, you're gonna have to rewind that videotape and show me, because I don't believe you. That's what I said. Oh. And so he rewound that videotape. You know what she was doing? She was doing this fast rhythmic hand clapping. And I said, that's one of those autistic tendencies. I go, we know all about autism, because her twin brother got diagnosed with autism the same summer she got diagnosed with epilepsy. That was the summer our lives went like this. Well, anyway, he goes, it's a classic simple partial seizure. But I go, she does that all the time and she walks and talks. But we had no idea that that was a seizure type 2 back then. You know, that was, what, about 10 years ago. We had no idea. So in a simple partial seizure, full awareness maintained, it could look like odd rhythmic movements like that. For other people, it's odd sensory symptoms. They get a funny taste in their mouth, only they just didn't get done eating lunch. I did a seizure education program for an elementary classroom a couple days ago. And one of the kids said, well, what does the funny taste in your mouth taste like? And another girl answered, well, I can tell you that. It's a combination. It tastes like NyQuil and chocolate for me. That's what it's like for me, she said. So that was kind of neat. For other people, they hear things that don't exist. They'll say, do you hear that ringing noise or something like that? And there's no ringing noises in that room. We had somebody in our support group a few years ago. She said, do you smell that skunk? And I'm like, no, we're in a library meeting room. You know, there's clearly no skunk in here. She goes, every time I get that skunk smell and I'm hooked up to the video EEG, it shows up as a simple partial seizure. Other people, they get a feeling of upset stomach. And this is an issue in the schools, you know, somebody's tummy hurts, they tell the teacher, well, what does the teacher do? They send them to the nurse's office. Only they send them by themselves. So they go to the nurse's office and it leads into a tonic-clonic seizure and they're having one in the hallway and nobody's there to help them. Other people get visual distortions. I was with a gentleman a few years ago. We were walking down the hallway. I knew he had simple partials and they were painting the walls and the fumes were strong. And I thought, oh no. And sure enough, the fumes triggered the seizure. The good thing is because he could walk and talk, I asked him questions. I said, well, what do you want to do? I said, do you want to go in that room? He goes, yep, let's go in that room. I want to sit down. So we went in that room. We sat down. He said, there goes my vision. And I said, what? And he said, I see a kaleidoscope. I see all colors of the rainbow. I've lost 90% of my vision. I can hardly see a thing. There were people sitting here, a secretary behind a desk here. And to them, it looked like two people walked in, sat down, carried on a conversation, and they had no idea he was in a seizure. Other people, it's psychic symptoms. They describe deja vu, hallucinations, been there, done that. Or they have a sudden feeling of fear, anxiety. But guess what? Nothing precipitated that in that environment. You know, could play out as behavior because it's an odd feeling, especially for those kids that are nonverbal. If they don't have a way to express their feelings on the communication device, then it comes out like that. One gal that I work with, she has these all the time, and she functions pretty good. And she said, you know, Roxanne, I have a really hard time putting into words what these odd sensory symptoms, because they come and go all the time. The best way I can describe it is that they're my funny feelings. When I get these funny feelings, that's what my simple partial seizures are. And even though I can walk and talk, she goes, I just want to sit down until it goes away. Simple partial seizures are actually the auras. So people who get those warnings, who can feel their seizures coming on, is actually a simple partial seizure. So these odd repetitive movements, odd sensory, odd psychic symptoms, they can come and go. But in other people, they can come and quickly, secondarily generalize into a bigger seizure like a tonic-clonic. They last less than a minute, but it can be confused with a person acting out, being a mystical experience, or even in psychosomatic illness. Now some people say, well, you just described all my symptoms of my migraines. These symptoms could be a host of a multitude of conditions, but these are the symptoms with simple partial seizures. And again, because the signs can be subtle and they could be different things, the only true way to know if those symptoms are a simple partial seizure is that they happen to have them while they're hooked up to the video EEG. Then the doctors will know by looking at that data. So a simple partial seizure, people can walk and talk, but a complex partial seizure, they can walk but not talk because their consciousness is impaired. And so because they can retain their mobility, people assume they can answer or respond to questions, but they can't. So like, suppose the kids are at school, they're in line basics, and Johnny wanders out of line. Well, the teacher's gonna go, Johnny, get back in line. Johnny's not paying attention. Johnny's not responding. Johnny is still wandering. So Johnny gets reprimanded for not following directions. And by the time he comes out of it and realizes he's not in line, he's in trouble and he has no idea why. So this event, the complex partial, again, a portion of the brain is involved. They don't have that ability to respond. This is what's commonly known as the wandering seizure. Have you ever heard people of wandering, confused, and disoriented? That's what a complex partial seizure is. So they're staring, and if they're upright, they're wandering, confused, disoriented. They have no purpose or direction. They could be wandering into things. A signature trademark symptom of this seizure is odd, repetitive movements. I was with somebody at our art therapy, we have an art therapy class to help people with epilepsy work their emotion, anxiety, and stress through art, and he had a water bottle, and he started tapping it. And I thought, oh no, here we go. He started picking it up, putting it down, picking it up, putting it down. He started pushing his chair in and out, like that, restless, like he was just, all of a sudden, he just got restless. Then he got up. Then he started, so the people were in group around here. He started picking things up, putting it down, just going like this. I touched his shoulder lightly, and he started fending off. If people feel threatened in any way, if people were to touch them, they're in that impaired conscious state, and it's just a natural reaction for them to push back or fend off or get aggressive. And so this one, it can be very tricky. Sometimes if they're trying to talk, their speech isn't making sense. Sometimes their lips will start smacking, but not always. 1 to 3 minutes on average is all the longer that it lasts. And when they come out of it, they're very tired. They may be describing a headache. A lot of people feel nauseated, their tummy's upset, and some people that have called in, they say, I vomit every time after these seizures because that's how upset my stomach is. So if you got somebody wandering confused, disoriented, not responding to questions, pushing back, fending off, this is the type of seizure that people can get wrongfully arrested for, because bystanders, if there's no familiar person with them, bystanders will call the cops because they'll say there's somebody drunk, or they think that they're drug abuse, or it could look like aggressive behavior. Some families with kids where they are so severe with their seizures, sometimes, so like if a seizure goes on and on and on and doesn't end on its own and they don't stop with medication, they call emergency services, they put in more drugs to an IV. If they can't get it to stop, the only way that they can stop that seizure is to purposely induce them in a coma to settle things down. Yeah, the really severe cases. Here's a few video clips of what a complex partial seizure looks like. So he's got the rhythmic hand tapping going, just kind of odd movement, some chewing motion with the mouth, staring off.
Part of the brain is affected. A person may still be able to perform gross motor skills,
So in this next one, he's tapping his soda bottle.
They may stare, mumble, repeat phrases, blink excessively, smack their lips, or pick at their clothing. However, they will be totally unresponsive to instructions because their consciousness is severely impaired.
Fending off what, at least momentarily, as a reaction, is thought of.
Is guide. You don't want to restrict them. You don't want to force them to sit down. That is the last thing you want to do.
So if you were to ever witness anybody in a tonic-clonic seizure, again, stay calm, track the time. The biggest thing with this one is do not restrain. You don't want to grab their arm and force them to sit down. You want to gently guide. They'll take the path of least resistance. I always try to walk, like if somebody were to be in one of these seizures in here and they're wandering, I would walk between them and the table. I would walk between them and the chair and the brick wall and the hazards. If there's other people in the room, we could stand in a circle and let them wander safely inside that circle. But you want them to wander safely without them feeling threatened. If there's a lot of noise and sensory overload in that environment, that could be very threatening for them and they could be getting very aggressive. So this one can be tricky because if you're outside and there's traffic, you know, you don't want to pull them and have them feel threatened and have a lot of behavior on your hands. So you want to talk softly, you want to gently guide, but also realize they're not going to be able to respond to questions. Never ever put an object in somebody's mouth during a seizure. Do not hold down or restrain their limbs as they're jerking or shaking, or grab them if they're in a wandering seizure. And do not give them food, drink, or anything when they're in a seizure. They would be at risk for aspirating on that fluid. Sometimes people don't know what to do and they're like, oh, here, take a drink of water. You don't want to give them a drink of water when they're in a seizure. Now, there is one rescue medication where you squirt it in the cheek of the mouth to help stop the seizure, and you would only do that if it was prescribed by that neurologist for that specific patient for that certain seizure type. Otherwise, we don't want anything going in the mouth during that seizure. Situations that are definite medical emergencies, if it's the very first time somebody had a seizure, we want to get them in, we want to get them checked out. A good rule of thumb is 5 minutes according to the medical professionals. Because if that seizure hits 5 minutes, it's longer than what seizures typically last. Most seizures last less than 3 minutes. But if it hits 5 minutes in length, then they may need help with medication and stopping that seizure. If the seizures cluster, that means if they have repeated seizures and they haven't regained consciousness from the previous seizure, then that is a definite cause for concern. Another reason why it's important to know what are common seizures for those children or for those you work with is because if they're exhibiting symptoms that is not typical, then that could be a cause for concern. There could be something else going on in that brain. If the person got injured during that seizure, if they took a hard hit to the head, they could have suffered a concussion. If it sounded like they fractured their limb, they need to get checked out. If that person has diabetes or they're pregnant, those are serious coexisting conditions that need to be checked out every time. It's a 911 call every time if somebody has a seizure in the water, even if you didn't see them go under. They could have taken in water, they could have gotten in their lungs, they could aspirate on that fluid, and that's something you don't want to find out about later. When the seizure is over, the breathing should resume to normal. If the seizure is over and the breathing is still very labored, that is a definite cause for concern. Any questions on seizure emergencies or the last couple of types of seizures with the complex partial and the simple partials? Have you ever heard of non-epileptic seizures? So over half of all the admits on epilepsy monitoring units are actually non-epileptic seizures, meaning they're seizures caused by other things. And they look like seizures. The seizure first aid is very similar, but the treatment options are incredibly different. Non-epileptic seizures are also called psychogenic seizures or pseudo-seizures. And sometimes we get calls from veterans. They relive the bombing or trauma from war, and they relive it in their head to the point where they're having a full-blown seizure. But it's not caused by abnormal brainwave activity. It's caused by reliving those events. And so seizure medication doesn't help someone with non-epileptic seizures. They need to see a counselor, and they need to get the kind of counseling and care to help them overcome reliving those conditions. We've also worked with families that have adopted children that have experienced such abuse that they're having these type of events. And so many times they're caused by a variety of psychological factors. I've also worked with people that were never abused or were not in the service, and they have these events, but it's caused by severe stress from their work environment. They have such high anxiety and stress that they can't manage it, and they're in these events. Seizure triggers. If there are known triggers, there's things you can do in that classroom or in that home or that environment to make it safer for those individuals with seizures. Now, flashing lights and hyperventilation are a couple triggers that many people are familiar with, but they're not triggers for everybody with epilepsy. Now, when they do the basic diagnostic testing, they'll roll in the strobe light cart, they'll flash the strobe light at different intervals, and they'll recreate hyperventilation by having them blow in a paper bag or blow on a pinwheel. And so the majority of the time, people generally know if these are triggers or not because they've been able to replicate that while they're hooked up to the video EEG. If you're working with somebody that lights are a trigger, you want to think about those fire drills, those strobe lights going off. That child could be going down in the middle of an evacuation process. You may need to adjust the tent on that video screen. There are certain video games that have those seizure warnings, and those are the games that are very intense and high paced that can cause seizures. So somebody where lights are a trigger, those video games with those seizure warnings would probably be triggers for them too. So you got to watch that. It could be that light bulb blinking out. Could be a trigger. We live in a techno world. There's a lot of restaurants and businesses that have flashing signs. A lot of people tell me it's very hard for them to ride in vehicles at night because of all the flashing lights or even the sirens, going by in the road. And those flashing lights can be triggers. Or even somebody sitting in a vehicle. The sunlight coming through a window a certain way as you're driving down the road, as you're driving by the trees, could have that strobe light effect. And same thing at our epilepsy camps when, kids are walking down the trail. Usually they got to wear some type of dark glasses to help filter the light, to help manage that. The number one reason somebody could have a breakthrough seizure is because of missed or late medication. People with epilepsy need their seizure medications on time every time. And this is the biggest thing with teenagers and young adults. They get very lax about taking their medication, and they don't like the side effects of their meds, so they quit taking it, but they don't tell their parents, they don't tell their doctor. If they're having severe side effects, they need to tell their neurologist. They can adjust the medication, they can help figure it out and manage that. But if they miss one dose of medication or get one dose late, they are at much greater risk for having a seizure. And if that person is driving, that is serious, because if you have one seizure in Iowa, it's under the loss of consciousness law. If you have one seizure, you cannot drive for 6 months. And so it's very important for people to take their meds on time every time. Stress and anxiety, this is a big trigger for a lot of people, especially for students. The week of standardized testing, the week of those finals, they are so stressed out that they're having seizures when normally the meds manage them pretty good. Lack of sleep. A lot of people tell me they got to have the same amount of sleep each night. If they have too little or too much, they feel off the next day, are more likely to have a seizure. And some people only have seizures at the night. So if they had seizures the night before, they could be falling asleep in class the next day because they didn't get a full night's rest. Hormonal changes. There's a type of epilepsy called catamenial epilepsy where the seizures only occur at the onset of the menstrual cycle. When somebody is sick, their seizure threshold is lower, even with a cold or cough. And sometimes the doctors will increase their medication until that flu or that sickness is over. If somebody is drinking alcohol or using drugs, those are triggers. Many people call in and say they can't even have one alcoholic drink because then they'll be having seizures. Or it could be prescribed medication with drug interactions. There's certain antibiotics, and there's also certain birth control pills that interact with seizure medications, resulting in seizures. The overheating and overexertion, this one was a big one for our daughter. We would often get the call from school during PE and recess. As soon as she would run and work up a sweat, she'd be going down in a seizure. Some neurologists recommend students sit out from PE for those reasons. Our neurologist recommended, he wanted her to fully participate and access those activities, but we had the safety measures in place on our IEP plan, on page F, and on our medical plan to make it safer for her. Poor diet, missed meals. There were days in school she didn't eat the lunch because she didn't like it. And she was having more seizures that afternoon. So we looked at the lunch schedule for the month. We'd circle the 3 to 4 days she didn't like the lunch. We'd send her the lunch that day to make sure she get 3 balanced meals a day. And a lot of my adult males that live by themselves, this is a big one because they're often skipping meals. They don't make their meals and they're not getting the nutrition they need. The heat, extreme cold temperatures, 90 plus degrees day in the summer, sub-zero temperatures in the winter, can be triggers for people waiting at the bus stops, or even if they're inside in that classroom and they go out for recess, that temperature change could be a trigger. Some people can't even go swimming because the hot air temperature and they walk into that cool water. That temperature change triggers a seizure. And certain smells, it could be that candle burning in that classroom. It could be walking through the lunch line, the smell of the spices, or like I said earlier, the paint from the fumes from the wall. So certain smells can be triggers as well. For people with intractable epilepsy like my daughter, you could manage everything on this list and she would still have seizures. The message is if there are known triggers, just manage the environment the best that you can do to make it safer for those individuals. So we are wrapping up on the hour. I wanted to touch on, are you familiar with the vagus nerve stimulator? So sometimes if the medications don't work, then the doctors will recommend this vagus nerve stimulator. And the generator is a round generator. It's implanted in the upper left chest. There's a coil that wraps around the vagus nerve and it stimulates the brain. The doctors program it to stimulate the brain. They don't know why or how the device works, but they know by breaking up those abnormal brain waves in some people can help manage or decrease the severe seizures. It doesn't prevent them. It comes with that black magnet, a high-powered magnet. So if you're working with somebody that has a magnet, all you do is you swipe the magnet. The implant is usually right here. So over the clothes, you swipe the magnet. It doesn't hurt them. All it does is it kicks it on. I've used the magnet a lot. A lot of people in my support groups across the state have this. I've swiped it in people. I've seen it stop the seizure instantly. That was nice. I've swiped it in people and I've seen it decrease the intensity of the seizure and the recovery time shorter. And that's typically what happens with a lot of people. I've swiped it in people and I've seen it do absolutely nothing. The seizure was still intense. And if that happens, you wait 1 minute and then you swipe it again. So this is a device and it's only FDA approved for ages 12 and up, but we do see this device implanted in a lot of infants and children if the meds don't work. So if you see this, you know they have epilepsy and you can use that magnet to help manage the seizures when they go in a seizure, which can be very helpful. Overall factors, you got people with seizures. Some people have medication side effects. Other individuals have underlying brain abnormalities, some with coexisting conditions. All these different things can impact the learning, the behavior, the self-concept, stigma, and psychosocial development. So even if their seizures are controlled with medication, it still can impact their learning at school or their ability to being able to work, and they still may need accommodations. The seizure video clips today were from our Understanding and Assisting People with Epilepsy video. So if you go to YouTube to the Epilepsy Foundation channel, you can find this video. We also have a seizures in school video, and you can watch the full videos. But this is where the video clips, so the seizure video clips came today. There's my contact information. I have 2 handouts, and one is a seizure first aid bookmark. And the red side is the first aid for the tonic-clonic seizures. And the purple side are the hidden signs for the partial seizures. And my number is the Des Moines phone number, my email, and our website is epilepsyiowa.org. We have all of our programs, services, upcoming events on that website. Our national website is epilepsy.com. It's a wonderful, credible website if you're looking up epilepsy syndromes, types, anything and everything you want to know. I have the 1-page handout. It covers the 4 seizure types I went over today, plus a few others, what it is, what it's not, what to do and what not to do, and again, my contact information at the bottom. So with that, I thank you for your time today. I hope you found the program informational.